Hi, my name is John Velyvis, board certified orthopedic surgeon with Precision Robotic Orthopedic Institute, or PRO-KNEE, in San Francisco, California. We work well with physical therapists, as we believe that the physical therapists are really the primary caregivers of most musculoskeletal problems because they spend the most time with the patients. They run patients through much more rigorous evaluations than we can do in an office setting and spend much more time with them. So the physical therapists we find are much more able to sort of have an inkling of what is needed, how the patients are responding to conservative care, and when there might be a need for more intervention and consideration for the need of a surgeon for injections or even surgery. Because they spend so much time, we choose to work well with physical therapists in pre-surgical care for all sorts of musculoskeletal injuries and diseases, as well as post-surgical care. They're the gatekeepers, the primary care of the joints, the musculoskeletal issues, the sports injuries, the arthritis problems that we see. They're on the front lines. They can tell when further workup is needed, when the modalities that they have in their physical therapy office need to be enhanced with a medical office such as injections and surgery. We want to work well with our therapists to empower them to order tests such as x-rays and MRIs without having to lose the patient to a surgeon and never receive them back. We work well with them and closely with them to make sure all the tests are ordered, listen to how the treatment modalities are going with our patients, making sure that there's full improvement, and in addition, we work well with our therapists in terms of post-surgical care of the patients rather than just keeping it in the surgeon's office. Well, for the patient, they get much more care. The physical therapists have much more ability to spend longer amounts of time, run them through more vigorous testing than just a quick physical examination. They know the knee joint extremely well inside and out. They can test all the ligaments. They can test for how they're responding to physical therapy and how they're responding to surgery. We believe that the older modalities of waiting for total knee replacement until someone's older are outdated. Therapists know very well when the treatments that they're able to render in an office are not being successful and more workup is needed, even in consideration for surgery. With robotic-assisted partial knee resurfacing, interventions can be done at a much earlier age and at a much earlier stage of disease to empower the patients to return to their function, return to their jobs, be more productive, and enjoy life much more without knee pain hindering them in any way. We definitely are able to treat a younger patient population at an earlier stage of disease. In addition, this partial knee resurfacing with robotic assist is also very beneficial for our older patient population as well. But this is definitely filling a treatment gap that has previously existed where some earlier meniscal tears and early stage sports injuries were treated well with arthroscopy, and then there was nothing for decades until someone was older and completely debilitated and needed a total knee replacement. With partial knee resurfacing, we fill that treatment gap. We're able to provide something that is extremely beneficial, very accurate, has a high level of success for our moderate-aged patients with a smaller area of disease, a smaller depth of disease, and then we can get them back to full capacity at work and at play much quicker and for a longer lasting result. If a therapist is treating a patient and is noting that they're not responding well to therapy modalities, we work well to empower them to order testing, to come in for physical exam to confirm what the physical therapists are seeing, to order x-rays and MRIs, and get those test results back to the therapist without the therapist losing the patient. And even if we do surgery, to empower the physical therapists to care for the patient post-surgically, spend a lot more time than we can in a doctor's office, and continue to enhance the recovery so that the outcomes are much better than without the therapists. If you look at an example of a professional sports team, the whole team is empowered to put that athlete in his best light as quickly as possible, and we need to be able to provide those same types of tools to our everyday worker and person who's experiencing musculoskeletal pains in the knee by empowering the physical therapists to continue the continuum of care for the patient. Even if there is surgery that's indicated, we believe that we'll get a higher level of function out of these patients. They'll be much more happy and live much more productive lives. There are three surgical compartments to the knee: the medial compartment, the lateral compartment, and the patellofemoral. We want to examine each of those compartments individually and very specifically on the physical exam. The same reason that we get these 4 specific views on x-ray to look at each compartment independently. We're looking for pain, crepitus, ligament instability, correction of a varus or valgus deformity, flexion contractions, and the like. We're testing all 4 ligaments of the knee, ACL, PCL, and the 2 collateral ligaments. And with this focused exam of the knee, we can really highly accurately predict whether partial knee resurfacing is something that would benefit the patient as a treatment modality. Typically, we want to make sure that we function with weight-bearing films, a standard AP with a straight knee, and a notch view with a bent knee can often unlock a lot of hidden arthritis and joint space narrowing. We also get a lateral and a patella sunrise view. With these 4 views, we can really cone down with a high degree of certainty the level of arthritis in each of the 3 compartments of the knee in order to determine whether someone qualifies for a partial knee resurfacing, or it's too early of a stage of disease to consider that, or whether all 3 compartments are involved and a total knee needs to be considered. So when we examine the knee, we're looking at the compartments individually instead of looking at the knee joint as a whole. So when we're thinking only about total knee resurfacing, it sort of doesn't matter where the pain is. We just look at the level of pain, the level of dysfunction, and an x-ray, and then we determine knee replacement or no knee replacement. When we're able to think more in terms of partial knee resurfacing, we want to find the location, whether this is reproducible on exam, whether this is where the patient is finding experiential pain on their activities, stair climbing, walking, and things of that nature, and confirm that that area is the same area as diseased on x-ray. And with these modalities of x-ray, physical exam, and patient complaints, we can really highly accurately predict whether partial knee resurfacing is a good treatment option. So a partial knee resurfacing is going to address only one surgical compartment of the knee, and we consider there to be 3. The medial, which is the most common, the lateral, which is second most common, and then the patellofemoral joint. By resurfacing only part of the knee, we're able to preserve the good parts without having to remove them surgically when they're not disease affected. We preserve all the ligaments of the knee, of which there are 4 crucial ligaments: the ACL, the PCL, and the 2 collaterals. A total knee replacement surgically transects 2 of those ligaments, the ACL and the PCL. It results in a higher level of dysfunction, a longer recovery, a higher rate of complications, more disability, less productive work years. And so we try to really evaluate carefully if a patient is going to qualify for partial knee resurfacing for all those benefits. Well, with the use of robotic partial knee resurfacing, the level of accuracy and precision of the installation is orders of magnitude greater than we've ever had before. The whole point of putting in, whether it's be a total knee or a partial knee resurfacing, is accuracy and precision, and aligning the knee to the patient's specific anatomy, getting the thing installed perfectly in a short order with minimal loss of bone, preserving good compartments, and preserving all ligaments. By doing this, we lessen complications, and we ease and almost cut in half the recovery time, and we increase the productive enjoyment of life for working and leisure activities for many years to come after the surgery. In the pre-technology age, ligament balancing was done sort of in a uniform way, the same for every patient. And now with robotic technology using navigation in the surgery, we can give a custom fit for every patient. And if you look at the knees of people on the street, you'll see that there's some people that are naturally bow-legged, some people are naturally knock-kneed, very few people are exactly straight down the line. So we return each patient to his natural state of anatomy that he should be at, and by tensioning the ligaments perfectly, which we are now able to do with these technologies, we give a much quicker result that is far outstanding to what we've been able to do before. But we now have good data, even though this technology is new, and we have studied the 2-year outcomes after robotic-assisted partial knee resurfacing, and found that in a multi-centered study that the early failure rate was 100 times less than the traditional outcomes that have been published in the literature in joint registries from 3 various countries as well as the United States. So this is really good evidence and proof that a proper installation with a high degree of accuracy and precision benefits the patient with longer lasting outcomes and lower pain scores. We love to do these surgeries in ambulatory surgery centers for the so-called factory focused model, which means that if you do one type of surgery repeatedly and often the same way, following rigorous protocols with the same surgical teams, same surgeons, you're going to get better outcomes. This is shown across many industries. The problem with hospitals is that they offer too many surgeries, they do too few of them, and there's too many changes back and forth with team members. And so if we can really focus in on a single thing and do it well, we're going to improve the outcomes and patient satisfaction, lower our complications, and save society money. We have seen many patients who have come in who have been told by other surgeons that the only surgery that they can have is a total knee replacement. When we reevaluate and start from the beginning with our highly refined protocols, we find that well over 50% of these people do qualify for partial knee resurfacing, which we believe holds so many benefits, preserving ligaments and preserving well-placed compartments that don't have end-stage disease for an early recovery and a longer lasting outcome, proven by science and outcome studies, that we have had excellent results of up to 50% of people who have been told by other surgeons that they need a total knee replacement. So in the first few visits with the physical therapist after surgery with partial knee resurfacing, we want the physical therapists to be looking and thinking about the same things that I would think about in the office. So some of the things in the first few visits that we look at is evaluation of the surgical incision and the wound to make sure about wound drainage, cellulitis, and healing. Because the first thing that we want to do is get a seal of that wound with a good scab and a scar with no leakage and no ability to obtain either superficial or deep infection. Next, we look for blood clot, DVT, by palpating the calf muscles and seeing if there's tenderness. Any concern would indicate a call to the physician, possibly even a referral to the emergency room for an ultrasound to look for DVT, and in a worst case scenario, even a pulmonary embolism. We want to be very concerned about any blood loss, anemia, heart rate monitoring, shortness of breath, anything that would be of a medical complication. And the physical therapists who are able to run patients through more rigorous testing than we can in the office oftentimes can unlock complications at an earlier rate. So we love working with physical therapists for those reasons. Post-operatively, physical therapy is very important to resume the patient back and get them on the best track for recovery. So we do gentle range of motion. Passive range of motion is really good with a physical therapist, slowly increasing our active range of motion. We eventually, once we get enough knee flexion, want to get them on a stationary bicycle. Really important metric is to get to 90 degrees of flexion. Once we get around the corner past 90 degrees, we know that we're on the road to good recovery. Occasionally, we will need to consider manipulations under anesthesia if we don't get that knee flexion. And so we love working with physical therapy on passive and active range of motion to decrease scar tissue formation and decrease swelling. We use ice packs. Eventually we get into whirlpool and heat packs and passive stretching. These are the most important early phase treatments. We cover from leaving the house to returning patients back to their house. Coming to San Francisco, you're taking advantage of the most experienced team with the most experienced surgeons who've done this procedure many times and are certified by the Pro-Knee Institute. There will be a care provider with you the whole step of the way. This will help with any issues of concern of travel, the discovery of any kind of complication or problem with pain, nausea, vomiting, other problems that might arise, and then accompany you on your travels back to your home until you're safely back in the care of your family and in your local physical therapy. Medical tourism has come to light in recent times in order for cost savings and for better care and outcomes. And there's really no reason it needs to be done outside the United States. So the definition of medical tourism is that we're wanting to see patients who are seeking the best treatment from the most experienced surgeons in order to get the best possible outcomes. And it can be done right here with cost savings in the United States. We are looking for cost savings and the best possible outcomes for all of our patients. At Optum Surgical, we coordinate the door-to-door care of the surgical experience, from pickup to the flight to getting you all your scans and testing done, the surgery, returning to your hotel, traveling back to an airport or car, back to your home. We cover it door to door. After partial knee resurfacing procedures, I have no specific activity restrictions. Your activity should be at a much higher level than after a total knee, and so we love to do partial knee resurfacings instead. I like to divide activities into three generic categories, which would be high impact, moderate to low impact, and no impact. And we would like patients and physical therapists to resume lower and no impact activities such as swimming, bicycling, walking, golfing, rather than the high impact. But nonetheless, we have treated many patients who have done high impact activities with a high degree of success and safety due to the robotic assisted accuracy of the implantation of the surgery. For DVT prophylaxis after partial knee resurfacing, our stress level is much lower than when we do total knee replacement because the bleeding is a lot less and the surgical intervention is a lot less. So the typical patient is placed on aspirin for 3 to 6 weeks, but we customize it for risk factors, medical comorbidities. Certainly if someone has atrial fibrillation or another need to be on an anticoagulant, we do use Coumadin, but for our standard patient who doesn't have risks above normal for DVT, we use aspirin, which is much easier on the system and allows for a quicker recovery with less bleeding complications after such procedures. Postoperatively, one of the main concerns that we have is infection. The most common infection we see is just a simple skin infection or a cellulitis, which is just treated with oral antibiotics. In order to prevent or decrease the likelihood of that, I send patients home with 5 to 7 days of an antibiotic taken orally just to prevent the superficial skin from developing any kind of infection. The major concern that we want to prevent is deep infection, which requires more surgery to clear that infection. And with less surgery, with partial knee resurfacing done in an ambulatory setting, this complication has been lowered dramatically. We use antibiotics at the time of the surgery given intravenously, and it's been found to be a very safe procedure with very low risk for infection. We are always checking the wound. We utilize physical therapy as well as nursing to check the wound with us, to report to us, and so with this very focused postoperative regime, we've had an extremely high success rate at Optum Surgical. After partial knee resurfacing at Optum Surgical, there are no stitches to be removed, no staples in the skin. Everything is done underneath the skin. We use dissolvable sutures. It takes about 3 months for them to dissolve. We use steri-strips on the skin, which are removed at about day 12 to 14. Patients can do it themselves, or the physical therapist or nursing can do it, as well as the doctor in the office. So it's pretty easy post-surgical management of the incision. Of course, there's dressing changes. We want to keep the wound clean with showering, soap and water, And with these protocols followed, we've had very low rate of complications. When we work with physical therapy, post-surgical patients after partial knee resurfacing, there's a couple benchmarks that we really look for the therapist to consider. One, of course, is the incision in the wound and the complications such as DVT, palpating the calf muscles. First of all, we're looking for independence of ambulation. How long does it take to get off of a walker and a cane? We've found it to be dramatically reduced compared to total knee replacements, and therapists have often commented how quickly patients recover after partial knee resurfacing. So we're trying to get rid of an antalgic limp, and we're trying to get a full extension of the knee, which is much easier to do after partial knee resurfacing. And then we look into flexion. So we're doing swelling reduction, passive knee motion, and active knee motion is started. If we can get past 90 degrees of motion, that's a sort of a critical marker that we look for within the first 3 weeks. Occasionally, we have some stiffness, which we love therapy to work on with us. Sometimes we do need to consider manipulations, so that's always in the back of our mind if we're not getting to that 90-degree mark somewhere around the 6-week mark. We look forward to working with physical therapists in the preoperative care and the postoperative care of these patients. We believe that therapists are on the front lines of care for musculoskeletal problems. They're there treating these patients, evaluating them much more than the ability of physicians in their offices. And we want to make sure that you realize that we are always going to return those patients to you and rely on you, and we want to empower you for testing and evaluation and working with you on our team. And so we look forward to working with you.